you. Actually, this is the second time I am chairing this session. Because in 2007, when he spoke on stem cells at Hyderabad in Southern Chapter meeting, there again I was asked to chair the session in the last minute. It gives me great pleasure to tell you that Dr. Kalluri is from this region of Andhra Pradesh, and prior to his present appointment as Professor Department of Cancer Biology, he was Assistant Professor, Associate Professor, and then Professor of Medicine at Harvard Medical School, Boston. Dr. Kalluri has several honors and awards to his credit. And to mention one or two, in 2005 he was awarded the American Society of Nephrology Young Investigator Award and the American Society of Biochemistry and Molecular Biology Young Investigator Travel Award in 1994. Dr. Kalluri has more than 50 publications in various international journals, and he has a very long CV. So with these few words, I invite Dr. Kalluri to give his talk on this very important topic. Kalluri, please.
Thank you very much. I'm very honored that you've invited me again back to this symposium. As it was mentioned, I was here attending this symposium in 2007, and I am delighted that you invited me to this symposium because I think most of my ancestors, generations, all have come from this region, from the region of Rajahmundry, Vijayawada, and Visakhapatnam area. So I'm delighted to be back to my roots here. So thank you very much for the invitation. I also want to thank the organizers for giving me this opportunity to speak, and I recognize that this is a very clinically oriented meeting, and I'm sure that those of you who have been very kind enough to come here after lunch and listen to a talk, you don't want to see it. Quite a few data-loaded slides about some experiments we're doing in mice. So my goal is to really use a story of how I did my research over the years and how clinical research really is what inspired me to do my work. This is a true story that no experiment that has ever been done in our laboratory is not driven by a clinical case that we saw. It puzzled us, and we wondered what we could learn from it, and we did experiments on it. So the goal is to then leave you with some idea of what chronic renal disease is as of today, what appreciation we have, and to give you an idea of what new drugs can be developed against it. I know there's tremendous pessimism and negativity about drugs that are being done in animals, and research is boring, and I hear all these things from clinicians. But I want to remind all of you that you would not have a single drug if it was not tested in a mouse or a rat. The question is why we're not doing more of it so that you have more drugs. So that is a challenge. But really you need experiments to really be done properly for the drugs to come to patients. In the area of cancer, which I'm associated with, in the last 10 years, there have been so many amazingly new drugs that have come into market and helping patients, all because of basic science research. And so we need to adapt the same thinking in the kidney field, because as you recognize, chronic kidney disease is a huge problem. I have this slide because everybody talks about it in a very local manner. But the most important thing is, can we cut some of this light down or something? So most important thing to remember is that there are about 250 million people worldwide who have chronic kidney disease. So don't think about just Andhra Pradesh or India or Asia. If you look globally, 250 million people suffer from chronic kidney disease. And in US alone, as the data is very solidly presented in many websites, $42 billion is spent to manage these patients. This is government spending. And globally, the estimate is $200 billion. This is an estimate because it's hard to really know, because some countries like India and China, it's hard to know even how much money is spent by the government. But the estimate is that today we're spending $200 billion yearly to manage our patients with chronic kidney disease. So this is a huge problem. This, in fact, is even bigger problem than many diseases in the world. So we really, in the kidney community, should focus on this and present this as a big case to most of our government agencies that this is a huge problem that we must tackle. I have this slide just to illustrate a simple point that it does not matter what the reason is for kidney disease, whether it is lupus that leads to lupus nephritis, whether it's diabetes that leads to diabetic nephropathy, toxic injury, drug interactions, whatever the injury is to the kidney, the first 50% of kidney loss is because of that injury. But the last 50% of loss of our kidney is due to fibrosis that sets in. This is a schematic that just illustrates that it does not matter what disease you're talking about. Whether it's a genetic kidney disease like PKD, or you're talking about diabetic nephropathy, the last 50% of our kidney function is lost because of fibrosis, not the original reason. So that is why it is important to understand fibrosis, because if we can inhibit fibrosis, then imagine it does not matter how the disease started. You can actually have therapy that can protect the last 50%. And you as clinicians will agree with me that by the time a patient comes to you, they probably are only having 30% of kidney function left. Because we have so much reserve in our kidney that we don't realize that the kidney is going wrong until it hits that critical point. So even if the patient comes at a 50% kidney sufficiency, you can actually come up with ways to inhibit it. You actually can prolong life of this person without any of the replacement therapies and transplantation, etc. One last point I would like to make is that we as physicians and physician scientists should never tell the world that dialysis and transplantation is therapy. It is just a replacement strategy. It is only to keep things alive, and we're doing it well enough, and we tell our patients that it is a way to keep them alive. But we really should not tell the world that we have a great way to cure disease or it is a therapy, because it is not a therapy. Anybody who's had a transplant will tell you that this is a lifelong battle they have to make sure that the graft is doing its function. And many drugs have to be taken to keep it alive. So this is all replacement therapy. We one day need drugs that we don't need to have those replacement therapies going on. So what I would like to do now is to just take you through a slight story about how my own career developed and how clinical observations led to discovery. And again, I might show you some data slides just to make a point that we actually did some things to discover what we did, but there's no reason for you to really understand the details of it, but just the main point of the slide. When I was 19 years old, I happened to have met a nephrologist, and this was just actually in a courtyard where we were having some gathering. And he found out that I was working with proteins that are that make up glomerular basal membrane. The glomerular basal membrane is our filter in the kidney. As you know, all our blood filters through it. We filter 180 liters of blood through our glomerular basal membrane, glomerular every day. And he told me about this case, that he just came across a 28-year-old woman who presented to the emergency room a few weeks earlier and had a 2-day complaint of dark urine, like a Coca-Cola, Coke-colored urine, and cough and bloody sputum. That's it. And he asked me, what do you think this is? And I, said, I don't know, I'm 19 years old. How do I know what this is? He said, well, this is the type of things that you should learn. We have no idea what this person has. We have some suspicions about what this person has, but we have no idea. And it turns out that this person at that time was diagnosed with what is called anti-GBM disease, Goodpasture syndrome, a very rare disease in the kidney, which I'm sure if most of you have taken any board exams in nephrology, it's a favorite question to ask because it's a very one of those rare classic autoimmune diseases. What interested me about this disease was that the only way to diagnose it was this presentation, because there's some problem in the lung, problem in the kidney, creatinine is high, proteinuria, and then when they did biopsy, crescentic glomerulonephritis, as you know. These are the classic pictures you see in textbooks. Crescentic glomerulonephritis, linear pattern of nobody knows it. And that is what I want to tell you, is that you, as physicians, are at the cusp of discoveries every day, if you want it to be. You're seeing patients every day who are challenging you to ask a question about why something is happening. Not basic scientists, not PhDs, because they don't see patients. You are the ones who are collecting the mystery. And this is a mystery. Linear deposits, you see these beautiful things. The question is, you see them, you diagnose, but ask the question, why? Why are these antibodies linearly depositing there? So then I went back and we had some discussion in the lab, and I said, I want to study this. I don't want to just isolate proteins from the kidney. I would like to study what this protein is that these patients are attacking with this antibody. And as you can see, these are pictures you see. This is the glomerular basal membrane. And so this is the glomerular basal membrane. These are the beautiful cells in the kidney that we know as podocytes. This is podocyte processes. These are endothelial cells penetrated. And this is through which we filter 180 liters of blood every day. That's how perfect this membrane should be for us to our kidneys to function. And this is just a scanning picture of the beautiful cells that are on the capillaries here. Now the question was, what does this glomerular basal membrane contain that these patients are attacking, correct? Anti-GBM disease is attacking this glomerular basal membrane. It turns out that it has many proteins. There are large proteins called lamins, collagens, etc. And they're very, very large in structure. Some of these are millions and millions of kilodaltons. So they're very large proteins of our body. So the question is, all these proteins are made up of glomerular basal membrane, but what is the antibody attacking? So what we found out, and this is again fast forwarding to you, is to tell you that a few years later we found out that the glomerular basal membrane contains as a main scaffold. So think about a sieve, you would like to get all the water through the sieve. So the main network of glomerular basal membrane through which the blood is filtering every day is made up of this collagen molecule called type-4 So that was discovered. So the question was, are patients making antibodies to this? Then it found out that as we were trying to identify what collagens are made, we found out that there are many types of collagens in the glomerular basal membrane. There's type 1, 2, 3, and 4. Doesn't matter, but we were discovering all these things. But the wonderful thing about this research was that any time we were isolating these proteins, what did we have with us to see if these proteins are the ones that the antibodies are binding? What we had was, when we were doing this research, it occurred to us that we need these patient antibodies. So I ran back to the clinic and asked this nephrologist, remember you told me that case, and you told me that this patient was being plasmapheresis. What did you do with those bags? He said, oh, we throw them away, but before we throw them away, we throw this cold room, and then the people in biohazard will pick it up. So we went and picked up 20 bags of plasmapheresis fluid. And all this plasmapheresis fluid had these antibodies. So for now, we have all these antibodies, and we can keep going, and every time we isolate a protein, we will throw it on it and see if it binds. So that's how the process went for another couple of years. And this, because of this transfer from MAC to here, something happened. But what we found out is that the autoantibodies from these patients, they don't bind here, but they bind to this alpha-3 chain of type-4 collagen. If you were to take a board exam, board certification for nephrology in the United States, I can give you one question you will always be asked. The autoantigen for Goodpasture syndrome is A, B, C. If you say alpha-3 chain of type-4 collagen, you get one question right. I tell you this because I was involved writing that question. And they usually ask that. It is a classic question. Then, of course, the question is, it was only one patient, remember? That one patient, that one woman really helped us discover this antigen, which is now in textbooks. You see any textbooks? All of this is there. Then the question is, are all patients doing this? So in Goodpasture syndrome, if you collect 58 patients, that's a big study because it's a very rare disease. So we had 58 patients, and 100% of them make antibodies to this. And this is the diagnostic now in the world. If you send it away to ELISA or some immunoassay, this is what they put on the plate, and this is if the antibodies bind, and the person is decided to have Goodpasture syndrome. Now, while we were doing this, I became much more interested in this sort of, identifying new things. So then another case came to this place, which was actually a patient who was transferred from Vanderbilt. And person is a 68-year-old male who presented with history of deafness, persistent hematuria, recent onset of proteinuria. So what do you think this could be? It turned out that this is another disease called hereditary nephritis, Alport syndrome. This affects kids because there's something wrong with their kidney when they're born, and then as they go into their teenage years, they develop this renal failure. So, as you know, Alport syndrome is actually a disease that is characterized by sensory neural hearing loss, ocular lesions, but structural defects in glomerular basal membrane. And in this classic textbook picture, you can see the basal membrane here. You can see all the splitting. If you compare between this and this, you can see it's nice homogeneous here, and all this splitting takes place. This is classic. I'm sure some of you, if you are diagnosed, this is a classic ultra structural picture of Alport syndrome. You can ask the same question. This is now 1990. We were asked this question: why should this patient have this structure? Just not take the fact that that's what diagnosis is. Try to find out why it is. To do that, we were trying to figure out what proteins might be defective in these patients. We came across another patient, and this patient really helped us discover many new proteins in the glomerular basal membrane and unravel this amazing disease with its mutations. And this patient was a 23-year-old male who had Alport syndrome, who had transplant. And this transplant, suddenly there was a loss of his allograft. Immunologists will not call this rejection because it was not lost because of the classic rejection that a graft can cause. It was just a loss of graft because the person had this massive elevation of creatinine, and a biopsy was performed to wonder why he suddenly lost this graft. And it turned out that this person had an allograft-associated placentic glomerulonephritis in the biopsy. Okay? So then, and it looked like a Goodpasture case. So look, if you compare this kidney section with another one, it looked like Goodpasture case. It turns out, again, we realized that these patients make antibodies. And 5% of Alport patients who make these antibodies develop this post-transplant anti-GBM nephritis that looks just like Goodpasture syndrome with linear deposits. Why would these 5% of patients develop this disease? And it turns out that the alloantigen to which they're making these antibodies is nothing but Goodpasture antigen. So then, this is now about 1992, and we wonder, why are they making antibodies to Goodpasture antigen? It turns out that the kidney they received from the donor, okay, had a protein in it that they never saw in their lives, because that's the protein that was mutated that caused this genetic problem. So when they receive this new kidney, they receive a brand new protein they have never seen in their lives, so they make antibodies. But 5% of them will launch T-cell response and other things and have this massive loss. But all Alport patients who receive transplants make antibodies because they've never seen this protein. And that was an amazing discovery because that showed us that the Goodpasture antigen, or whatever that protein is the one that is defective in Alport syndrome, through connection. And developmental biology studies show how glomerular basal membrane form first, how capillary structures form with these proteins, and how they become mixed with glomeruli. And the reason I'm showing you this is because to appreciate to you that if you have one of these chains, one of these proteins mutated in Alport patients, then the other two that was associated with are also gone. So Alport patients, that's why, if you were to look at their glomerular basal membrane, they should have structures that are like this, but they lose all the proteins and they all look like this. And that is what you see in renal fluorescence. This is diagnosis. If you were to take an Alport patient's biopsy and you look for alpha-5 chain, you will not find it. Alpha-3 chain, you will not find it. Alpha-4 chain, you will not find it. All you will find is alpha-1 and alpha-2. And that's how all of these descriptive diagnostics can be explained by this study. So that's how you look. An Alport patient will only have 1, 2, 1, 2, and 1, 2, whereas these proteins are all missing. And when you don't have these proteins, which are very important structural proteins to make sure that our filtration happens properly. Remember, 180 liters of blood is filtered through this. So if you were to buy a brand new car and you have an old set of tires on it, tires will go away first. And that's what's happening to these kids. They're born normally, but as the filtration pressure increases, they don't have these special proteins that are crossing much more. And so that's why this kidney starts splitting and breaking. And a genetic disease where one of the collagens is gone. We made a mouse where the collagen is deleted from their genome, so they develop the disease. So these mice would develop Alport-like disease and they gave us a chance to do some therapy studies. So we went into some stem cell studies to ask the question if we can use stem cells to replace the protein that is missing. And we generated the stem cells, we made them in preparations where we know that we can inject the mice. And the question was, can they go and fix this problem here in Alport patients and create this new material? And this is just to illustrate to you that in these mice you can see this effacement of podocytes, which I know you know as a clinical term. This splitting of the basal membrane that patients see. When you give stem cells, the basal membrane becomes normal, and you can see the pattern of food processes like a normal medium here. So obviously it can fix the problem. But very nicely you can see here, this is your Alport patient, right? There's no alpha chain, no alpha-4, no alpha-5 because of mutations. And when you give the stem cells back, you can reproduce them. And this led to improving the function, etc. And now there's a trial starting at Children's Hospital Boston where I think they're going to try this because there are other ways that we have found we can make these stem cells. So then the question is, you know, as my life went along, diabetic nephropathy became something that I was interested in. And these are the two cases that really puzzled me, and they continue to puzzle me. And as a clinician, you come across patients who are diabetic patients who have, you know, one of them, let's say, this one here, is a 48-year-old male in good health, strong family history of type 2 diabetes, is diagnosed with type 2 diabetes, placed on insulin sensitizers, is a compliant patient. This is a patient that we love, right? They listen to you, they do everything, they're wonderful. And the second patient is the same case, but had no compliance. He's your nightmare patient, doesn't listen to you, doesn't take drugs or anything. But a few years later, this patient who is very compliant developed massive fibrosis, and the kidney was gone. Whereas this person here, who is non-compliant, who is not a good patient, he's doing very well. So this proves to you that it isn't about just the primary disease that determines the end, but there are other genetic events that we have. Some people will progress to end-stage renal failure much faster because there are certain genes that make them go there, versus some patients, even if they have the same insult, same diabetic insult, they somehow don't progress. And that became an interest for us because, again, coming back to the idea that fibrosis is what is causing the problem, is there a way that these patients are reacting? And this autopsy study really is the one that tells you that there's an issue. Here's autopsies of about 3,200 kidneys of people over the age of 70. And if you were to take these kidneys and don't tell the pathologist them from autopsies and have them analyze it, they'll find that 25 to 40% of them have significant glomerular interstitial fibrosis. Because the pathologist doesn't know where it came from, so he'll say there's zones of it. Because with age, we develop fibrosis. So as we age, we develop fibrosis. But only 2% of all these kidneys had actually documented dysfunction. So what I'm trying to say is that it doesn't matter if you have lupus, diabetes, or genetic disease, there's something else that makes the kidney go faster to the end stage, and that fibrotic process is what we have to understand. Because we understand it, there's drugs that we can come up with that actually can impact that. Because if you come up with those drugs, then they don't have to be specific